Thank you everyone for joining for the Cancer Care from an Employee Perspective webinar. My name is Jennifer Schaefer and I will be your WebEx host for today's meeting. Before we get started, I'd like to go over a few housekeeping details. All lines are in listen-only mode. Please submit your questions using the Q&A or chat panel and select all panelists. You may need to activate the appropriate box using the floating navigation panel found at the bottom of your screen. Please note this webinar is being recorded and will be available later online, and we will let you know once posted. With that, I will turn it over to Dr. Michael Halpern.
Good afternoon. I'm Michael Halpern, a medical officer in the Healthcare Delivery Research Program, and it's my great pleasure to welcome Dr. Shaylin Buck, who is the Chief Medical Officer of Lockton Dunning Benefits. Dr. Buck is, as I said, the Chief Medical Officer for Lockton, serving as a health and welfare strategic consultant for U.S. employer clients and specializing in clinical data analysis to inform actionable cost and risk mitigation solutions. Dr. Buck received her MD from Emory University and completed residency and fellowship training in clinical pathology and transfusion medicine, also at Emory University. Prior to joining Lockton, Dr. Buck served as Medical Director and Vice President of Health Integration at Marshall & McLennan Agency, Executive Medical Director at DeKalb Medical Center in Atlanta, Senior Medical Laboratory Director of Quintiles Laboratories North America, and Assistant Medical Director at American Red Cross Biomedical Services. She also recently participated as a member of a panel at the 2021 ASCO annual meeting titled "Stop Doing It, De-Implementing Inefficient Clinical Practices." So it's my pleasure to turn the presentation over to Dr. Buck.
Thank you so much, Michael. And let me go ahead and get my screen set up here for everyone to see. And it's such a pleasure to be here. And I wanted to just kind of set the tone for today's presentation. It's really a practical and kind of conversational tone. And the intent of this is for knowledge sharing and really to open the door for some collaboration opportunities. And so as we go through the information today, certainly welcome questions coming across. I hope I have answers, but this is, as we all know, healthcare is moving into really, it has been moving into really interesting space. So would look forward to us kind of exploring these topics together. One of the things that that I'll add to my bio is that I am also a licensed insurance broker in Texas. So you'll find out why that is an interesting piece to the work that my colleagues and I do every day on behalf of employers. I will tell you, this is one of those things that we never learned in medical school. I think we should have a whole series. Doctors should get together and have a series of what you didn't learn in medical school that's important to how healthcare is delivered in this country. So I had to learn a whole new language, new terms, jargon for this industry and in working with employers. So I hope that I am we'll describe some of that as we go through, but certainly if there's a term that's used and you have a question or want further elaboration on that, feel free to enter that in the Q&A box. So for our discussion today, what we really are looking to do is to provide an overview of employer-sponsored health insurance and why that's really important to the payer, provider, and the patient conversation. And we'll start with that broad lens and actually broaden that lens a little bit further and talk about employee benefits and why employers have employee benefits, how the health plan fits into that benefit strategy. And then we'll narrow that down and start talking about cancer, particularly around self-funded employers. And I'll describe what self-funded employers are in a moment. and why that topic is particularly of interest as we think about cancer care and high value care. And then we'll talk through some of the interventions that we are having conversations about with employers, what they're considering as they structure their health and welfare benefits as relates to cancer. And then at the end, we'll have a Q&A session that Dr. Halpern will facilitate. And that's where I think we'll start to have some additional conversations around where there's opportunities to drive high value care. And really, at the end of the day, achieve the quadruple aim on behalf of employers and the members of their health plan and their employees. And really, just as a point of reference, the quadruple aim, again, is looking at cost effectiveness, the quality of care, access to care, and access to that care when people need it at the time that they need it, and also the patient experience. And I think that as employers historically have looked at healthcare, they've just seen dollar signs. But in our conversations with employers, it really is beyond just the cost of healthcare. They are looking at how quality of care, the member experience, and access to care can be enhanced through the benefits that they're offering to their employees. So as a point of context, because you're probably asking the question, what the heck is a pathologist doing in this space? And I've always found myself in this position where I have helped to bridge clinical and business, or clinical and regulatory, clinical and quality. And so having had that background, it certainly comes into play with the work that I do at Lockton. So what is Lockton? Lockton specializes in consulting for employers around their different strategies. So it could be risk management strategies, health and welfare strategies, would be mergers and acquisitions. So we have several different arms that we deliver consulting through to employers. The area that my colleagues and my clinical colleagues and I really focus on is around employee benefits consulting. And you can see how that plays out, the details here, how that plays out in the work that we do with employers. But the bottom line here is that my colleagues and I, we really sit at this intersection within healthcare with the employer as a payer and representing them and their employees and the family members that are on the health plan, then working with providers and the what we call carriers, and I'll describe that in a minute, which are the insurance companies, and also increasingly in the conversation with healthcare innovators. So oftentimes those are entities that are outside of the traditional health system. So you're hearing more about groups like Amazon, or you'll hear about Grand Rounds or Teladoc Health. We're at the table with those groups as well. And what we think about employers, we work on behalf of employers. We are talking to employers every day. We live and breathe employers in the work that we do. And as I mentioned, I'm so fortunate to work with other clinicians, nurses, doctors, pharmacists, population health specialists. We also work hand in hand with actuarial scientists and data analysts, leave and absence experts, HR experts. And so it's really nice to have that multidisciplinary team to guide and inform the work that we do with employers. Many of my colleagues have joined us today. So hi to all of my Lockton colleagues that are participating in the webinar. So again, I want to broaden the aperture first and talk about why employers offer health and welfare benefits and what really fits within that scope. And then we're going to narrow that down and talk about specifically the medical and pharmacy plan, the health plan that employers offer. So what we are seeing and hearing about, and even in our formal surveys of employers, we're seeing a lot of activity that just extends beyond the health plan, but certainly relates to the health and the well-being of employees. We are definitely seeing a need around mental health and well-being. We're seeing a lot of innovation around navigation tools that help employees and their family members navigate the healthcare system. And we're seeing innovation around engaging them in the healthcare system. We always say that, you'll hear about utilization, about healthcare utilization, oh, that's bad. And we say, no, there's actually good healthcare utilization. We want people to engage with primary care. We want them to engage with preventive screenings. So there's a lot of activity around how to best identify and engage individuals in healthcare. A lot of focus on diversity, equity, and inclusion. We all know that COVID really magnified health disparities in this country. And as it relates to the work that we're doing with employers around health and welfare, that's translating into strategies that employers are asking us to help them with around health plan, identifying health disparities through the health plan and implementing strategies. And so I'll give you some examples of that as it relates to cancer. A lot of work around virtual care. We saw within our book of business when I say book of business, our clients, our self-funded clients in particular, we saw 1,500% increase in the use of telemedicine during the time of COVID. And we are seeing employers say virtual care is here to stay, and we want it to see it as part of the healthcare ecosystem. Costs are certainly front and center with employers. We all know that healthcare costs continue to rise, and I'll explain why that's particularly important to what we call self-funded employers. Pharmacy is big, especially when we talk about cancer therapies, immunotherapies, and as we see more and more of those enter the market. And also we have a specialty practice that focuses on absence management. And that gets into questions around leave and disability. And so increasingly, we're working with those specialists to look at how we can extend the conversation around health and well-being to the employee productivity and absenteeism conversation. So why do employers offer benefits? Why do they offer a health plan? Well, there's a legal reason for offering a health plan, but what we know is that employers actually see health and welfare benefits as fundamental to both attracting and retaining talent, and they actually care about their employees and family members. We definitely, in our conversations, hear that front and center. They want to be able to be part of the solution in promoting health and well-being in this country, and see their role as an employer as an important vehicle to do that. They are very interested in reducing cost, but really, when we say reducing cost, their interest is around high value care. Understanding that there is a cost to healthcare, but making sure that the care that's being delivered is cost effective. So now let's start to narrow down that lens and talk specifically about health insurance that is delivered through the employer channel. What I think when I first started in this space, I was fascinated to learn that almost half of Americans get access to health care through employer-sponsored health insurance. And that, when people would ask me, well, wait a minute, Dr. Buck, do you miss patient care? I'd be like, wow, I actually am feeling very fulfilled in the work that I do, because there's this huge channel through which, the employer channel, through which the work that my colleagues and I do, where we can influence healthcare. And so that's, I think really fundamental to the conversation that we're having today, is that if we're going to affect healthcare delivery in this country, employers have to be front and center in that conversation. They are a key delivery channel, and they are also an important payer. And we'll talk more about that in a minute. Just some of the key notes around health insurance as it's delivered through employers. We all know that by law, employers that have 50 or more employees, they must provide affordable health coverage. And that healthcare, with that being said, is actually one of the top budget items for employers, along with labor cost. But these benefits and the health plan are critical to employers attracting the talent that they need for their business to keep their business running and retaining that talent. There's a lot of competition among companies around the benefits that they offer, and it's one of the key things that that candidates for a position at a company will look at as part of their decision making. And then as it relates to how employers fund healthcare, if we think just about a health plan premium, not the claims cost, which we'll get to in a minute, but just health plan premiums, employers pay 83% of the premium cost for single coverage, so that's an employee only coverage, and then 73% of premium for family coverage. So just with the premium alone, employers are taking on a large percentage of that cost share. So I mentioned a couple of times the term self-funded. And this, again, was very new to me when I entered this space, understanding how, through the employer, how the health plan is actually financed. And so there's really two major ways in which a health plan is funded. There's a fully insured plan, and what that means is that an insurance company actually takes on the risk. They pool the risk of a bunch of different employers, and then they set a premium and they take on the financial responsibility for the members that are part of that health plan. And then they actually hold on to that money. So if an employer's population is performs from a plan perspective, a healthcare perspective, does better than what was projected, the insurance company keeps that money. Now, certainly if they don't do as well, they have higher claims cost, then they certainly receive the benefit of that risk pool. But increasingly, we are seeing employers adopt a self-funded strategy. So what does this mean? And this is really, really critical to the conversation. What this means is that the employer takes on direct financial responsibility for the cost of healthcare within their plan. What does the insurance company do? The insurance company just acts as an administrator, and we'll walk through the details of that in a moment. They act as an administrator, and they are not taking on financial responsibility. So the employer contracts with the insurance company to do administrative services only. So then there's another layer that self-funded employers will apply, and that's called stop-loss insurance. And so this is becoming really important as we're seeing healthcare costs skyrocket. And what stop-loss insurance does is it accounts for catastrophic claims. And so that allows for some financial protection for the employer, but with that stop-loss insurance, there comes another premium. And so there's cost associated with that as well. So why do employers, if they're taking on all the risks, taking on the cost, why do they elect a self-funded option? Well, it gives them a lot of flexibility. It gives them, if their population health is good, the population's being well managed, then certainly they see the benefit of that. There's also some tax and legal reasons why employers would elect to be self-funded. And so with that, we are seeing about, I would say nationally, what we see is about 61% of employers are actually self-funded. When you start to look at the larger employers, so those that are that have 1,000 or more employees, that number increases to 86%. So with the larger employees, 1,000 plus, or larger employers, 1,000 plus, far and away, they are taking on full financial responsibility for the employees and their family members who are on the medical and pharmacy plan. So how does that kind of start to translate to the cost that the employer will see? When we look at our book of business, so the clients that the self-funded clients that we can see all the data on, what we see is that a member's average annual medical and pharmacy spend is around $6,200, and the employer pays about 85% of that claims spend. So it's a pretty big, chunk of change. Now, how that spend is distributed over the plan population is certainly not equal. So what we are seeing with self-funded employers is that there's a decreasing group, a smaller and smaller group of the population that's driving the majority of the spend. And that's really where cancer comes into play and conversations around kind of the quadruple aim in impacting cancer. So we'll talk a little bit more about that. In terms of stop loss coverage, so mention that that's that catastrophic coverage. The employer pays an additional premium for that. That premium is adjusted based upon the deductible amount. So as with any insurance, you increase the deductible amount and then the premium will decrease. We see a broad range of premiums that are set. So it can be anywhere from around $10 per employee per month, all the way to several $100 per employee per month. So you can do the math in your head. You got 1,000 employee group, and then that's an additional cost. But then with that deductible in play, it gives that employer added protection for those catastrophic claims that reach that, what we call the spec level, the deductible level. Now, where do we see that deductible level often sit? It can be anywhere from an individual member perspective, with an individual member that hits 150,000, all the way up to, we have some employers that have $1 million deductible. But when we look at across our data, kind of put a pin in the in those members that spend 100,000 or more in medical and pharmacy claims, and we have specialized services around that group, and so that's really where we set our threshold for looking at catastrophic claims. So when we look at that across locked-in clients, less than 1%, 0.6% of health plan members spend 100,000 or more per year in medical and pharmacy claims. And that group alone, less than 1%, represents 30% of an employer's total claims spend. So, and as I mentioned, over the past 5 years, 10 years, we've seen that number shrink. So this concept of the 80-20 rule that we heard in the past is actually now 80. If we just take that 80% of spend, that 80% of spend is driven by 8% of members. So it's the 80%, 8% rule now, not the 80%, 20% rule. Some of the reasons for that is that with the ushering in of the ACA, it actually eliminated the pre-existing condition exclusions, annual lifetime maximums, and so it really removed the cap on an employer's financial exposure. On the flip side, there were caps that were put in play. One in particular is what we call the out-of-pocket maximum for employees. And what this did, it limits the employee's financial exposure by limiting the amount that an employee can pay in deductibles, co-pays, and co-insurance within a plan year. So what that means is when a claimant a member hits their out-of-pocket maximum, which can be anywhere between, there's IRS rules around this, but employers have flexibility in what they can set with an out-of-pocket max, but that can be anywhere from, you can see it $3,000 all the way up to $10,000. Typically, we see it within that range. So what that means is, we'll just use $10,000. If a health plan member hits $10,000 in claims and they're out of pocket spend on those claims, then the employer pays 100% of all of the claims above that threshold. So it's really important to remember, obviously, around cancer, because cancers represent some of the highest cost claims that employers will see. In addition, employers have seen about a 6% increase year over year in the health plan spend, and obviously that's at a faster rate than GDP. And then as it relates to stop loss, stop loss probably 5 to 10 years ago was just not as critical as it is today. Because healthcare costs are increasing so much, we're seeing that with self-funded employers that have stop loss in place, which the majority do, 86% can expect to have a stop loss claim in a single year. And even more striking, the percentage of $1 million claimants is continuing to increase. Since 2017, based upon Sun Life's report, Sun Life is one of the largest stop loss carriers, the stop loss $1 million claims have increased by 31% since 2017. So it's a big, big increase there. And then there was a question that came in before the webinar around coverage of retirees. We actually don't see a lot of employers covering retirees anymore, but nationally, only 29% of employers have a retiree plan. And we typically see that with public entities, or we may see it with groups that have a union population. But one of the strategies that employers have been implementing has been reducing or eliminating their retiree plans. So now let's talk about the insurance company, the big bad insurance company. Well, I talked about jargon that we have in the world that we play in with employers. We have a term called BUCA. You may use this too, but it's the BUCAs. So when we think about self-funded employers, we talked about, well, why do they need an insurance company? Well, the BUCAs, which are known as Blue, United, Cigna, Aetna, the big four. I know Humana is number 5 as it relates to Medicare, but these are really the big four players as it relates to employers. The BUCAs are also known as carriers in our jargon. And what the BUCAs do is they actually are contracted to provide a variety of services. They adjudicate claims, they provide customer service to members, they create medical coverage policies to make sure that evidence-based care is being covered. They also have utilization management programs to make sure, this really ties into high-value care, to make sure that high-value care is being delivered. Case management, where you have nurses who are supporting the most complex members and guiding them through the healthcare system. But they also are increasingly providing buy-up health management programs. And this is where cancer also comes into play. So I have some statistics over here, descriptive statistics from our Locked-In 2021 client survey. And we asked a bunch of questions, but one of the questions we asked is, are you getting additional services, buy-up services, or paying more for services from either the carrier that you have as an administrator, or are you going and purchasing in the market what we call third-party programs that are outside of the carrier? And so what we see is that for the most part, we see a lot of employers that are purchasing these health management programs. They're primarily purchasing them through the BUCAs, through the carrier. We are, however, seeing an increasing number of employers look to third-party innovation solutions and starting to purchase those. In cancer, we are starting to see in the market cancer solutions, third-party cancer solutions, that I'll talk about a little bit more in a moment. We are starting to see those emerge in the market as well. So let's talk about the self-funded employer health plan population profile. So my Locked-In colleagues on the webinar are probably going to laugh and know exactly what I'm about to say, but we often say that this isn't Medicare. And the reason we say that is because oftentimes we will see providers, health systems, for example, we'll see different health management or disease management vendors, third parties come to us, and they'll quote national statistics around things like diabetes. And we have to remind them that that is not applicable to our population, the employer's population. So what I'm showing here on the screen are some statistics around the demographics and chronic condition profile that we see within our locked-in client, self-funded client book of business. And this is pretty typical for what you see outside of locked-in with other data sets that we've looked at that look at the employer health plan population. What we see is the average age, they're young. So just under 34. The reason for that is because the employee is not the only one that's covered under the health plan. In fact, just it's really half and half. We look at the health plan, you see half employees and half family members represented by children or domestic partners and spouses that are on the plan. So one can see here that with children, also known as dependents on the plan, that's going to drive down the average age. But we also know with employees, their average age is around 45. And so it's a younger population out of the gate. What's also important is that when we look at the age distribution, only or less than 3% of the health plan members are over the age of 65. And we also don't see as many chronic conditions on the plan as we would with the Medicare population. And so this results in a bit of a different profile. Obviously, you're not going to see maternity and pediatrics in Medicare. So we have to think differently as clinicians and supporting employers about the types of risk and programs that an employer would need to have in their strategy. I'm not going to spend a ton of time on this slide, except to say we're looking at a lot of different dynamics with employers as it relates to their health plan. A few of the pieces that I want to note is that there's a term that we use called high cost claimant. And a high cost claimant is it's a term that's really used in the commercial space, is an individual that spends $50,000 or more in medical and pharmacy claims per year. When we look at that group represents 2% of an employer's health plan population, but just under 50% of an employer's health plan spend. When we look at that group as well, and we look at those that have cancer within the high cost claimant group, the average spend per high cost claimant is just over $170,000 per year. Specialty drugs are a key factor in driving this increase in spend. We're starting to see immunotherapies that are hitting the claims experience. And we recognize, and we are saying to employers that yes, these cancer treatments are critical, they're effective, they're important, but there is this increasing concern about the cost, as you can imagine. So then let's take that down another level, and let's look at this. This information represents our locked-in self-funded clients. Let's look at how cancer plays out within the population. And there are some differences in what we see with national statistics. We see breast cancer as the most common cancer. However, right underneath that is leukemia and lymphoma. Part of this is because we have a younger population, we have children. Another, we talk about nationally lung cancer being one of the most prevalent cancers. However, when we look at an employer population, it's lower on the list. The reason this is important is just as we think about cancer strategies, we have to think about what types of cancer are we seeing within the population, and then we have to think about what are strategies around those. Another important factor that we look at is as we look at the cost of cancer, what percentage of that spend is attributed to those cancers that have a population-based recommendation for a screening test or exam. We call those early identifiable cancers. And the spend attributed to early identifiable cancers is around 30%. The majority of the spend, 70%, is on what we refer to as non-early identifiable, where a physician will have to pick up on signs and symptoms, or the patient will pick up on signs and symptoms in order for that cancer to be identified. As I mentioned, and this is just some statistics around what we see with engagement with primary preventive care and cancer screenings, which we track for employers as well. But I think what's really critical is that employers, as we talked about that out-of-pocket maximum, the financial exposure that an employee has, that cancer patients typically hit their out-of-pocket max, so employers are often paying 100% of a member's cancer cost. Just a few highlights on the stop-loss insurance pictures specifically. So we talked about the health plan. Well, let's talk about how cancer is manifesting within the stop-loss claims. And cancer is at the top. And what we see is that's actually increasing. This is based on Sun Life data as well. And when we look at stop-loss claimants, the number of people with a stop-loss claim related to cancer has increased by 16%. In addition to that, the cost, the actual average cost related to their care has increased. And so this cancer is now serving as one of the top drivers for increased premiums, stop-loss premiums, so making stop-loss insurance even more expensive. So we also, our team has really an obligation to support employers with managing those costs so they don't hit the stop-loss deductible level. Yes, it's a protection, but it's not something that you want. It's like a life preserver. You don't want to just be sitting in the life preserver all day. You ultimately want to be able to get to shore and get out of the water. What about specialty drugs as a subset of the cancer spend? This is actually based on Sun Life data as well, but the costs here represent what we call first dollar cost. In other words, this is the cost that the employer is paying, but also with stop loss would likely kick in for many of these drugs. And what we see here of the top high cost injectable drugs, cancer therapies represent 12 of the top 20. And immunotherapy drugs now are well represented within the top 10, and you can see those laid out here. And so there are a lot of strategies that are specifically looking at how to manage cancer drug costs. And we know, as part of the conversation too, with immunotherapies, with the treatment cost, you have the drug cost, you also have the hospitalization treatment cost over $1 million. There's a lot of economic and bioethic concerns. I mean, we're talking about employers who are just trying to keep their doors open and keep their business running, and they're getting hit with $1 million claims. So, and that hits their bottom line. So really, you can see why that's important. And I think another thing that we have to think about too is, yes, we are applauding cancer survival rates, we are applauding maintenance drugs, but that is definitely changing the picture and the financial exposure that employers have and need to account for in their budgeting. So with all of that being said, you can probably appreciate that employers are saying that healthcare must change. And with self-funded employers being the predominant type of employer that is sponsoring a health plan, you can appreciate with that financial impact that they're seeing, that they're looking for healthcare to be taken beyond the status quo. And they were passive participants, but becoming very active now in the conversation. As of this year, the National or the Business Group on Health revealed in their most recent employer survey that while just a few years ago, only 27% of employers were like, our benefit strategy, our healthcare strategy is just table stakes, right? It's there, we got to have it. Well, now 45% consider their healthcare strategy to be a key part of their overall business and workforce strategy. And what's also more compelling is that 24%, and I would imagine this is even increased from when the survey was done, they said that they won't wait for the traditional healthcare delivery system to change. They're ready to partner with innovators and become active in driving healthcare delivery change. So what does that mean as it relates to cancer strategies? Well, there are really three major categories where we're seeing employers ask about and consider and even implement strategies around cancer. They are looking at coverage, so asking questions about what should be covered under the plan, and also about plan design. So implementing networks that include centers of excellence and really requiring the members to, or that is an in-network solution versus out of network. So looking at centers of excellence and trying to drive members to those centers of excellence for high quality care, seeing focus on genetic testing and genomics and how precision medicine can come into play on a cost management perspective. We're seeing a lot of different financial models. Bundled payments, I imagine most people know what those are, but we're also seeing reference-based pricing models that are starting to be part of the conversation. So what this means is that the employer will pay a fixed payment to the provider. It's typically based on Medicare as a reference and then adding a percentage. So you'll hear things like 200% of Medicare or 300% of Medicare. Typically are 150 to 200. We're also seeing outcomes-based pricing models discussed, particularly around immunotherapies and high-cost treatments. So in other words, if the treatment doesn't work, somebody has to reimburse the employer. So that's kind of interesting. We're definitely seeing direct contracting and carve out cancer services from the health plan. So the employer's directly contracting for those services versus looking to the carrier. And then there are steerage incentives. So employers are paying for travel, they're waiving co-pays, deductibles, co-insurance if their members go to high value providers. And then on the medical management side, seeing a lot of solutions come into play here, expert medical opinion, second medical opinion services, definitely seeing NCI designated cancer centers now coming out actually with employer products, and also being positioned as in network only, and then just on and on. So a lot of different strategies here. Virtual care is actually becoming interesting too from an access perspective, and creating a vehicle through which an expert, a cancer expert, can work directly with a community oncologist and create alignment on behalf of the patient. And so the patient may go to a cancer center for diagnosis, but then the treatment plan is managed through the community oncologist. So the technology is proving to be an interesting play to allow for that continuity and access. And then finally, as we broaden the lens again, how are employers then looking at their cancer strategy across the prevention to high cost need? And so we're seeing employers implement just a broad spectrum that looks at health promotion. We're looking at prevention, promoting screenings, and then all the way to clinical management for those members that are diagnosed with cancer. And then broadening that further, employers are then asking the question, how does their cancer strategy fit within the broader ecosystem? And they're actually designing now, instead of just having these siloed services, they're now designing ecosystems that help to navigate the employee and their family members effectively through healthcare, and then asking how these different pieces can connect to each other, so creating interoperability. So that's definitely increasing part of the conversation with employers. And then lastly, I know that this is an important topic for NCI and ASCO. With COVID, we are having conversations around health equity all the time. and employers are asking, where are the health disparities? What can they do about it? And what are some of the strategies that they can put into play? And as this relates to cancer, this is just an example with colorectal cancer of some work that I did with an employer where I went through and described some of the disparities. I realize I'm not representing all of the disparities here, but some of the categories or populations where we see disparities, and then walking through with the employer what they could do about it through their health plan and through their benefit design. And so I think that serves as an opportunity, as I mentioned, for collaboration. Potential collaboration is how can we impact health disparities related to cancer through the employer channel. And so I look forward to hopefully having some more conversation around that. So again, that was just a pretty quick hitting broad view of what we're seeing in the employer space. And I hope that that helped to open your eyes and open the door for us to continue our knowledge sharing and also to collaborate on potential opportunities. So with that, I will hand it back over to Dr. Halpern to facilitate a question and answer session.
Well, thank you, Dr. Buck. That was wonderful. That was a terrific presentation, and we've got a number of questions through the chat. Please continue to send questions in, and we'll get to as many as we can before our time ends. So let me start with some of the questions we received. There were a number of questions that asked about employer involvement in survivorship care programs, so programs to support employees after cancer treatment ends, both in terms of employee healthcare needs and in terms of workplace accommodations, and wonder if you could say anything about that.
Well, I'll start by saying thank you for the question, and I'll start by saying that I think is an opportunity for us to have continued conversation. And we mentioned that people are surviving. More and more people are cancer survivors, and that is necessitating a different set of services to support them through the employer. And we are definitely hearing employers ask about it. And so that really fits within several of these areas that I had talked about earlier, but one in particular is around well-being. And we are seeing where there, with cancer and survivor well-being, where there are services that are now available that have support. So employers can provide, support programs. There are programs through their employee assistance program, or what is also known as an EAP. Increasingly, we're seeing EAPs, which used to be used for critical mental health needs or critical substance use disorder needs, now being repurposed to provide things like support services for members with cancer. And from a leave perspective, we definitely want, and employers want, their employees to be productive and happy in the workplace. And so I think that's another area with our leave experts of how you can create accommodations that allow these survivors of cancer to effectively work and contribute to the employer's business. And so we don't have a lot of definitive answers there, except to say that there's a lot of activity in that space and a lot of opportunity, I think, moving forward.
Great, thank you. You had commented earlier in the presentation about employers wanting virtual care to continue, and there had been a question about speaking to the regulations around that, particularly where physicians or other healthcare providers might be, not quite sure what the question was getting at, but might be licensed in one state, but are being asked to provide virtual or telemedicine services out of jurisdiction, and are employers having conversations with regulators about those kind of licensing requirements?
Absolutely. I will say that there's several things that are happening. First of all, COVID has put definitely a microscope on virtual care, and has resulted in a lot of efforts on the regulatory front to try to drive that. There's even a group that is, and I hope I get this name right, but there is a lobbying group that is, home, I forget it, but basically their whole focus is combining virtual care and home care, to bring the site of care to the home. And that Amazon is actually one of the groups that's leading that effort, along with a lot of health systems. And so they're looking at that regulation for better reimbursements from a licensing perspective. So can we create some type of national license versus just the state by state licensing approach? So we expect that there's going to continue to be some regulatory movement there. We also expect that where telemedicine, which telemedicine is different than telehealth, as you may know, telemedicine is really specific to the use of technology to diagnose and provide a treatment plan for a patient. That's different than telehealth, which is a bit of a broader category that looks at things like remote patient monitoring, looks at even text-based, support, maybe with a physician extender or social worker. So that's not as strictly regulated as the diagnosis and treatment piece of telemedicine. But to really just land the plane on that question, we see that yes, employers are part of that conversation. Telemedicine providers that are working with employers primarily are pushing that conversation. And then we're seeing big players in this space like Amazon and Google and others that are driving that conversation as well.
Great, thank you. So there's a question about asking you to comment on adjustments to HR paperwork. Commented about it that it really does not function well for intermittent treatments such as chemotherapy, and asking for your thoughts about that.
Maybe that's related to disability, the question around disability and disability claims, so that the provider has to provide information to support a disability claim. Is that maybe, or is that what that's related to, Michael? I'm not sure.
I'm not sure either. Just
okay.
It just says comment on adjustments to the HR paperwork.
Yeah, and so that's so I did kind of operate in that space in the past, but more.
So it's not for disability, just leave.
Oh, for leave, yeah. So I operated in that space a little bit in the past. To be frank, that is not my space anymore. But certainly I can follow up with some information from our leave experts. But I would agree that especially for complex conditions, it is, for leave purposes, it's a pain. So I'm not going to deny that. I have looked at it through the provider lens and looked at it through the employer lens and through the patient lens, and it needs improvement. So I hear you. I just don't have a good answer on how that can be improved right now.
Thank you. So there were a number of questions about cancer in the working population. There was surprise about the numbers of cancers in the working population, surprise about more cancers in the working population compared to the Medicare population, and asking about that, and also asking about what kind of activities do you see among the locked-in clients to encourage cancer screening among their working populations?
Oh, absolutely. So let's see if I know where to start. So I think this is the slide that probably prompted that that question, and maybe it was this slide as well. I mean, this is huge. This is a very different population, as I said, and that certainly plays out with what we're seeing with cancers. And in fact, I was talking to it was a leader within one of the major cancer centers, and she was saying, hey, let's talk about health disparities with lung cancer. And I said, that's great, would love to, but we don't see a lot of lung cancer in our population. Part of the reason for that is when lung cancer manifests and that employers have tobacco cessation programs, and they even will put in tobacco surcharges, which means that a member who is using tobacco, if they don't go through a tobacco cessation program, is going to have to pay more for their, basically it's a higher premium for their health care. But, I think that as we look at this, part of this too is driven by pediatrics. And this is where I think we have a great opportunity. Is there's not a lot of there's a lot of attention being paid to high value care within the adult population and within the Medicare population. But we are definitely seeing, because as you saw, about 26% of our health plan members are children or under the age of 20. So really in the pediatric population. And we are definitely seeing that there's an opportunity with children's hospitals, with cancer care navigation, with the pediatric population. There's just not as much there as there is for the adult population. So I think there's a lot of opportunity to create navigation programs, specialist programs where those kids with cancer can be better navigated, and quality of care kind of oversight increasingly with pediatric cancer care. I don't know. I think I meandered there a lot.
That's great.
But I guess the point is, I think there's a great deal of opportunity for us to further explore the population profile and how cancer manifests within the employer population, as we look at what you're doing with your healthcare delivery research program. I mean, there's just, and even with health economists, and I think there's just so much fertile ground here. Oh, and the cancer screenings. I have to tell you, this is really cool. We were actually, before the U.S. Preventive Care, I can't get it, the USPSTF, right? Before they even talked about doing cancer screenings, lower the cancer screening age to 45, we were having that conversation with employers because we were concerned about the patterns that were within particular demographics. And so what's nice about the self-funded employer is they have a lot of flexibility in what they can do with their health plan. And they often couple that with engagement and health promotion programs. They'll even bring, mammograms up into the work site so that people get access to mammograms. So we definitely see a lot of attention being paid to the to cancer prevention and weight management. They are increasingly interested in weight management because of the 13 cancers that are associated with unhealthy weight. Definitely seeing weight management beyond just tobacco cessation as a key part of their prevention strategy.
Well, thank you. I think we've come to the top of the hour. I want to be respectful of everyone's time, but I'd like to thank you again for a wonderful presentation. Provided a lot of terrific information. I'd like to thank everyone who attended and look forward to continuing to speak with you about potential opportunities to collaborate and move forward in the future.
It was certainly my pleasure. Thank you, Dr. Halpern, and thanks to everyone who joined.
Have a good rest of the day.